Talking to you about mechanical ventilation, in particular liberation from mechanical ventilation, which is also known to many people as weaning. But we'll talk about why that word is a little bit controversial. So why do we want to discontinue mechanical ventilation in patients, and why do we want to do it so fast? As you know, probably from your ICU rotation, once you intubate a patient, you've probably been told that the goal is to safely extubate as soon as possible, and that is indeed the case. The reason is that positive pressure ventilation is inherently damaging to the lungs. All sorts of trauma is created by positive pressure, including volute trauma, barotrauma, and even trauma due to atelectasis. So for instance, when the alveoli collapse and re-expand, that steadily depletes the alveoli of surfactant and can cause a lot of damage down the road. Now, the term weaning implies a long and gradual process of successive reduction in ventilatory support. But in reality, it doesn't have to be so incremental. If you intubate someone and their problem is largely resolved, sometimes you can have them extubated rather promptly. So that's why the term weaning is falling a little bit out of favor, and a lot of folks prefer the term liberation or even discontinuation of ventilation. I should make a note that the process of weaning or liberation can compromise over 30% of the time on the ventilator. So if someone's on the vent for 10 days, it can take 3 days or more to get them off. So it's a process that takes a lot of work and planning, and I'm glad that we're learning about it. The duration of the extubation process varies quite a bit, and I wanted to share some terms with you that might be interesting to learn about. First is simple liberation or simple weaning, and that is when you assess a patient, you decide that they are eligible for spontaneous breathing, you go through your algorithm, and then you extubate them soon after that. Difficult is when this process takes 2 to 7 days, and prolonged is if you've been trying for more than a week to get someone off the ventilator and it's just not happening. You might have heard of the term failure to wean, and that can mean a number of things, but often it means someone who has failed a spontaneous breathing trial several times in a row. It can also mean someone who is extubated and then re-intubated within 48 hours. The issue of reintubation is a bit complicated and has sparked a lot of discussion in the critical care community. So in general, someone who's been recurrently reintubated has a poor prognosis, and it's associated with a significantly higher mortality than the norm. Some people say up to 3 to 11 times the mortality rate. Nationally, the reintubation rate is about 20%, and that's higher than what we'd like. Ideally, your reintubation rate should be 10% or even a bit lower. The reason is that if your reintubation rate is 0, that might mean that your criteria is excessively stringent. So it is something we think about, and indeed someone who is being reintubated many times usually has multi-system organ dysfunction, which again has been linked to poor outcomes. In general, a protocolized approach is the best way to get someone off the ventilator. And I'd like to describe 3 steps that you might take to make that happen. First of all, the most important thing is to ask yourself every day, is my patient ready to wean? How do you know if this is the case? First of all, the underlying disease process has to be largely resolved. So if they came in with a severe pneumonia and they were intubated because of that, the pneumonia should be mostly resolved or at least moving in that direction. In addition, some degree of hemodynamic stability is needed. So if someone is on 2 or 3 pressors and you're escalating on those medications, it's not a good time to initiate the weaning process. You'd like the patient's FiO2 to be less than 40% and the PEEP, or positive end expiratory pressure, to be less than or equal to 5. In addition, your patient should be able to undergo a spontaneous awakening trial, also known as a sedation holiday, which is when you discontinue sedation and you can assess their neurologic status. Some patients are extremely agitated, and that can impede the weaning process. Your patient in general should be somewhat awake and alert and able to initiate their own breaths in order to start the weaning process. I mentioned briefly before the term spontaneous breathing trial. And many of you know what that is, but just to review, it's when you put the ventilator on minimal settings and the patient is initiating their own breaths. So it's supposed to approximate independent breathing as best as possible. So the protocol continues. The second step, once you've decided that someone is ready to wean, is to perform the spontaneous breathing trial. And we do this with the assistance of the nurse and the respiratory therapist. So we do this first by minimizing sedation before the spontaneous breathing trial. If someone is very somnolent, they're not going to do well. Precedex or dexmedetomidine is a good drug to give if you are putting someone on a spontaneous breathing trial because it doesn't depress the respiratory drive. You might have heard of the term dextubation, and sometimes when we have very agitated patients, we'll put them on Precedex and start the SPONT trial that way. I then generally turn the pressure support to 5 and the PEEP to 5. The pressure support of 5 helps you overcome the resistance of the endotracheal tube, and again allows for an approximation of regular breathing. A T-piece trial in certain instances is also acceptable. A T-piece, if we remember, is a device that we put at the end of an endotracheal tube after we have discontinued the circuit. So the patient is essentially breathing the air of the room without any assistance from the ventilator. As you might guess, this is a very demanding process for the patient because they have to essentially breathe through a narrow diameter tube, kind of like breathing through a straw. So we don't do this very often, but we do it in patients who are maybe marginal and we really want to assess their muscular strength. So it is acceptable to use that if you're not sure whether the spontaneous breathing trial went well. During the spontaneous breathing trial, we monitor for signs of distress, including tachypnea, tachycardia, agitation, and desaturation. If any of these are present, I would say that the patient has failed their SBT. In addition, one number that we like to look at is the rapid shallow breathing index, which is the frequency of breaths divided by the tidal volume. In general, you want this number less than 105. If the number is higher than this, it suggests that the patient is breathing in a rapid and shallow fashion, and that again tells us that they perhaps don't have the neuromuscular strength to breathe independently. So moving on, let's say you've put your patient on a spontaneous breathing trial and they did well. There's no agitation, no distress. They had an RSBI of 70, that would be good. As a third step, I like to perform a final readiness assessment. I make sure that the patient has an adequate cough and gag. And the nurses and respiratory therapists also chime in on this issue. We want to make sure their secretions are under control and they have an adequate negative inspiratory force and vital capacity. Those are again measurements of muscular strength. We want to make sure that a cuff leak is present. As you know, a cuff leak measures for laryngeal edema, and your respiratory therapist can help with this. If there's not a cuff leak, the patient might need some adjunctive steroids to help reduce the swelling. We check on their neurologic status and make sure they can track and follow basic commands. And then finally, I like to make sure that the nurse and respiratory therapist agree with the extubation. Ideally, this should be a team decision with everyone on board. Sometimes we run into a problem where our patients repeatedly fail spontaneous breathing trials. And there are things we can do to optimize them for success. First of all, we can focus on increasing their muscle strength by ensuring adequate nutrition, correction of electrolytes, correcting an underlying metabolic acidosis, offering physical therapy, and reducing the steroids that we give, because steroids, and especially steroids and paralytics, have been associated with muscular weakness. Fluid balance is very important. It is hard to extubate a patient who is very volume overloaded. So getting them to an appropriate fluid balance, as negative as possible, is generally the favored approach. We also want to work on sputum clearance and address any wheezing issues. Finally, we want to make sure that the patient's respiratory drive is preserved, and we'd like to reduce sedating medications whenever possible. Post-extubation. Once you've extubated your patients, some patients do perfectly fine and continue to get better. Some patients, especially those with excessive medical comorbidities, such as neurologic disease, CHF, COPD, might need assistance from high-flow nasal cannula or non-invasive positive pressure ventilation after extubation. In general, if my patient needs this, I try to give that sort of therapy for a short period of time because these patients are at high risk for progressive respiratory failure, and we want to be on the lookout in case they require reintubation. So as a rule, I watch these patients very carefully, and if they do need adjunctive therapies, we try to do it for a relatively short period of time, or at least ensure that they're improving. For folks that have been intubated for a long time, the road to recovery can be a long one. Prolonged intubation can lead to muscular weakness, issues with speech and phonation, even tracheal stenosis. If your patient has had multiple failed spontaneous breathing trials and has been intubated for quite a while, or has been re-intubated a number of times, we need to make sure that we're having the difficult but important conversations we should be having. Questions such as tracheostomy, goals of care, or palliation are all very important to discuss and should be initiated as soon as possible. In summary, positive pressure ventilation damages the lungs. Let's try to safely extubate patients as soon as possible. A protocolized approach with a daily spontaneous breathing trial is favored. Patients with multiple comorbidities, such as CHF, COPD, and neurologic disease, are at higher risk for a prolonged wean and/or reintubation. So these patients should be managed very carefully, and after extubation, they should be watched closely. Though there are ways we can best optimize patients, spending weeks on mechanical ventilation is very challenging for the human body. It'll require us to initiate important conversations with the patient's family rooted in overall prognosis and goals of care. That being said, we do successfully extubate patients at Highland every day, and I wish you the best of luck in all of this. Please call your pulmonary and critical care colleagues for advice at any time.